All right, welcome. I am Casey Albin. I am a neurointensivist and a clinician educator. I'm coming to you from Emory University, and I am so delighted to be here today to talk through what's really foundational to this course, which is the fundamentals of neurocritical care. And I'm someone who really likes case-based learning, so we are going to kick this off with a sample case. And this is a 27-year-old man who presents to the ED after a high-speed motor vehicle crash. On arrival, he is not opening his eyes to noxious stim. He has no vocal output, and he is only withdrawing to noxious stim on the right side. So he is a GCS of 6. And you're worried, appropriately so, about a traumatic brain injury with increased ICP. And I think that all of you here are taking part of this course because you want to know, how can we manage this patient to prevent secondary brain injuries and improve his neurologic outcome? And that is the goal of what we were going to do today as we work through the fundamentals in neurocritical care. And we really can't do that without first understanding a little bit about cerebral physiology. And before you get worried, because that could sound boring, I want to tell you that this is going to be simple. It basically all boils down to the intracranial anatomy essentials, which is the Monroe-Kelly doctrine. And what this basically says is that the skull is a box. Only so much stuff can go in the box. And if there's too much stuff in the box, then the pressure in the box rises and herniation occurs. So I love this graphic to sort of help us understand the way that the brain is balanced normally. So in a normal, healthy human, there is brain in the CSF and brain in the skull. There is CSF in the skull. There is also blood volume, which is both the venous component and the arterial component, which you can see if you're looking at the top of the screen. And the brain is amazing. So it can do a lot to accommodate that purple mass. So the way that it can make room for that is it can shunt CSF out of, down into the spinal column. It can also promote venous return, which it does through complex mechanisms that allow a little bit more venous drainage. But at some point, those mechanisms for sort of dealing with this increased mass, those are exhausted. And so that's when we get this pressure, that the components are no longer able to shift around, and that pressure within this fixed space is going to start to rise. And so as we think about cerebral pathology, we're really thinking about, well, what's the extra stuff that can go in the brain? Turns out you have a lot of pathologies that go in the brain. This case is focusing on trauma, but you can also have intracerebral hemorrhage. You can have tumors. You can have edema, either from a, sort of subacute stroke, from an infection, from something like a demyelinating disease. That too can take up mass. Or you can have additional CSF, and we term that additional CSF hydrocephalus, right? And so when we are worried about a patient presenting with trauma, with a traumatic brain injury, and we're worried about ICP, what we're really worried about is this state where the extra stuff, that purple component, is larger than what can be accommodated by the brain's normal mechanism for CSF diversion and venous volume return. And so why does it matter if the pressure starts to elevate within this fixed skull? Well, 2 reasons. The first is that you diminish your brain perfusion, right? And that is causing a secondary hypoxic brain injury. And if that sounds confusing, let's unpack that first. So cerebral perfusion is dependent on the mean arterial pressure of the body, the systemic pressure, minus the pressure that is resisting blood flow into the brain, which is the intracerebral pressure, or the ICP. And so how much pressure the arteries feel to perfuse the brain is determined by the mean arterial pressure minus the ICP. So you can imagine that if the ICP rises, that cerebral perfusion pressure will fall. Now, fortunately, the brain is quite smart, and it uses complex mechanisms through cerebral vascular resistance, or CVR, to help control the diameter of the arteries so that pressure, as it varies, the cerebral blood flow, the flow of the blood that's ultimately into the brain stays the same. And so I think it's a little bit easier to see that on this slide. So I want you to focus on what's in the green area there. So you'll see the bottom of this chart is, oops, let me go back. The bottom of this chart or the graph shows your CPP in millimeters of mercury. And you can see in the green area, when your CPP or your MAP minus your ICP is anywhere between 50 to 150, your brain can do a pretty good job of keeping the cerebral blood flow, which is on our y-axis, constant. That's a good thing, and it does that by changing the caliber of the arteries, right? So as you have more pressure, it will narrow those arteries to provide a little resistance so you don't get too much blood flow. As you have less pressure, it will expand those arteries so that you can still get enough blood flow through that lower pressure. So again, what's really important here is that when your cerebral perfusion pressure falls below 50, you're really in the danger zone. And I've circled that in red because that's the point where you get cerebral ischemia. That is secondary injury. And so you can imagine that if your ICP is so high that it's causing your cerebral perfusion pressure to fall, then you can have secondary injury. You know, the brain is sort of like Goldilocks. It doesn't like things out of too much or too little. So you could also have kind of a bad situation if you have too high of a cerebral perfusion pressure. And we're going to talk a little bit more about that in a different lecture when we cover PRESS. But for now, I really want you to focus on that your cerebral perfusion pressure less than 50 is going to cause ischemic injury, secondary brain injury, which is why it's so important to keep your ICP low so that we are not causing unhappiness to the brain. All right. The second reason it matters if ICP is elevated is because herniation occurs. And again, this is coming back. I really love this diagram so much. So herniation simplified. You can no longer put more venous volume out. You can no longer put CSF into the spinal column. What happens? The brain gets out of the box, and that is not a good thing to exist for our patient. Now, herniation has a bunch of different type of subtypes of specific herniation syndromes, but all of them share the final pathway that there is going to be coma. And the coma is a result of the compression and disruption of the reticular activating system, which is a really complex neurologic circuitry that exists in the brainstem. And when the brain is pushing down on the brainstem, that's disrupted and the patients go into a coma, right? So I am always so worried about our patients who have a GCS of less than 8 after any sort of traumatic event, because that to me says that there is compression on the reticular activating system. Now, of the herniation syndromes, uncle herniation, which is type 3 in this diagram, is the most well-known, and I think it's the most important. What happens in uncle herniation is the middle temporal lobes, which kind of sit right beside the brainstem, are pushed over by a mass. So you can see that in the diagram that you have the supratentorial mass. In this case, this is looking like a subdural. That subdural is pushing on number 3. And number 3 then pushes on the brainstem, which is in the middle of the brain there. This can be clinically recognized as an ipsilateral, meaning on the same side as the mass lesion, there is a enlarging or blown pupil, and on the side opposite to where the mass in the brain is, there is contralateral hemiparesis. This is a really, really important thing to look for clinically, especially with thinking about pupillary changes. One of the things when residents or when fellows or when our ED colleagues call us, one of the first things I ask them is, what are the pupils doing? Because if one of the pupils is dilated, that tells me we are in a life-threatening situation for a patient who's in a coma, and we need to act fast. Transtentorial herniation or downward herniation also can happen. That's number 2. Again, that's just direct downward pressure on the reticular activating system, which is causing coma. Subfalcine herniation can actually impinge upon the anterior cerebral artery, which can cause ischemia to the area that would result in ipsilateral to the lesion. We talk about everything regarding where the lesion is in the brain, at the level of the brain, leg weakness. Tonsillar herniation, again, is a really life-threatening situation because the posterior fossa is a very small space. So if you have pathology in the cerebellum, it can rapidly compress the brainstem, leading to flaccid paralysis and respiratory arrest. This is a really rapidly evolving sort of situation. We should always respect cerebellar pathology. So I want to emphasize and review here that there are real bedside clues that you can look for on your exam. So that's that altered mental status for any patient who has, at risk of a neurologic impairment, a new unilateral pupil dilation, and any abnormal posturing, whether that's decorticate, where the arms pull into the core, or decerebrate, where you're posturing out. Late signs are sort of historically talked about in the context of Cushing's triad, which is hypertension, bradycardia, and irregular respirations. But I will tell you, as someone who has seen many unfortunate herniations, that it does not necessarily end with bradycardia. Sometimes tachycardia can also be a really important sign to notice. So, key clinical principle: herniation is a clinical diagnosis. You can do this even before the patient gets to the brain scanner. So please, if you see a patient who is in a coma with a dilated pupil, think that is an ICP crisis. So what are you going to do? Let's dive in to management. So our big picture goals here are that we need to avoid secondary brain injury. I always tell patients that the initial brain injury is kind of like the genie in the bottle. It comes out or it's there, and I cannot put the genie back in the bottle. But what I can do is make sure that we prevent more injury from happening. And the way that we're going to do that is basically keep the brain in its happy environment. So we are going to prevent hypotension and hypoxemia. We are going to maintain a stable MAP with fluids and vasopressors. Remember, MAP is directly linked to cerebral perfusion pressure. So if your MAP gets too low, that's also putting your patient at risk for more hypotensive and hypoxic ischemic changes. And that is not good. And then, of course, we are going to aggressively reduce the ICP. And we're going to get into a lot more details about how we're doing that. But if you take nothing else away, the management of ICP boils down to this graphic again and the ways that we tailor our approaches based on the component that we're aiming to sort of reduce, right? So we want to make more room. Well, we can do that by promoting venous return, which is elevating the head of the bed, keeping the neck midline. We are going to try to not terribly reduce arterial blood volume, but maybe make sure that it's not too much by hyperventilation. And we'll talk a little bit more about how we do that. We are going to think about, do we need to divert CSF? Do we need something like an external ventricular drain to help us? Or can we dehydrate the brain through hyperosmolar therapy? This is really the key take-home slide. So if you want to, save nothing else, this is what I would tell you to save. And now we're going to get into a little bit more details about how each of these work. The way that I approach this is kind of step one, thinking about, do I need a neurosurgeon's help? So there are a lot of things that we can do with medicines, and we can take really good care of patients with high ICPs at the bedside, but there are some things that are just going to need a neurosurgeon's help. So you need to get them on the phone. Or if you do not have neurosurgery at your shop, you need to find out, how can I get them there as soon as possible? Things that we're looking for: obstructive hydrocephalus, a lateralized mass such as a subdural, epidural, an interparenchymal hemorrhage, cerebral contusion, and in some large cases, even ischemic strokes can cause mass damage and will need a decompressive hemicraniectomy. So here are some examples. You need a surgeon's help, right? So in the first example, we see obstructive hydrocephalus. In the second, we see a subdural hematoma causing midline shift, right? So I always tell people, look at the scan and first decide, is this a medical management problem, or is this a surgical management problem, or is it both? Now, while you're temporizing the patient, or if the patient has, not a lateralized lesion, such as our patient in this case, who has sort of diffuse brain trauma, we're going to think about acute management of elevated ICP with medical interventions. So this is adapted from the fourth edition of the Brain Trauma Foundation Guidelines for Severe Traumatic Brain Injury. And I really like to think about this in a tiered approach where we are escalating our medical management to sort of higher risk treatments that may have diminishing returns and really trying to maximize doing the things at the lower tiers, which, are helpful for all patients and have less risk, right? So tier 0 is kind of what should be done for all patients. We do not like our patients with sort of increased intracranial pressure. In this case that we're going through, our hypothetical brain trauma patient, we don't want them to be agitated. When they're agitated or bucking the vent or having horrible pain, that's going to increase their MAP, which could, worsen, put them in sort of that dangerous hyperemic perfusion. If they are not, if they then get too much pain control, then they may go on the opposite direction and their MAP is too low. So we really want to be gentle with our patients. The head of the bed elevation is so crucial for patients. Why? Because it promotes venous return. A lot of our venous return is going through the internal jugular veins, as all of you I'm sure know. And so when our patient's laying flat, we're not having gravity work on our side. Same thing for patients who have had trauma and they're in a C-collar. If that C-collar is compressing their internal jugular veins, that can actually limit the amount of venous return and can worsen their ICP. And so sitting the patients up, making sure they have pain control, making sure their C-collar isn't on too tight, all of those are really important strategies for all patients, but particularly patients who have suspected or confirmed intracranial pressure. So this is just a summary of that. I don't think it really matters which kind of sedation you're going for as long as it's gentle and you're not doing too many boluses. Again, you're just trying to limit agitation. We're aiming for a RASS of -2. So this is not to deeply sedate patients. We've talked about head and neck positioning. So let's move along to tier 1. This is that hyperosmolar therapy, hyperventilation therapy, and CSF diversion. Hyperosmolar therapy is sort of the cornerstone of ICP management. It's using an osmotic gradient to pull fluid from the brain and therefore lessening cerebral edema. Now, it's really important to recognize that to work, this requires an intact blood-brain barrier, right? So the osmolar therapy is actually shifting water from the cells that have an intact blood-brain barrier, the normal healthy cells, from the cells themselves, pulling water out into the vascular space where you have administered that hyperosmolar treatment, right? So you can either give mannitol or you can give hypertonic saline, but both of those are going into the vasculature. That vasculature then goes up to the brain, and the brain says, hey, that has a higher osmolarity than my cell does, so I am going to shift water from the cell, so dehydrating the brain. That is working to make more room for the abnormal tissue, which really can't shift the water out of the cell. Now, should you use mannitol or hypertonic saline, which are our two sort of cornerstone treatments for hyperosmolar therapy? And I like to say, are you kind of a sugar person or a salt person? Both of these can really work, and there is not great evidence to support one or the other. So to spend just a little bit of time, we're going to talk pragmatically. Mannitol is usually given 1 gram per kg dosing. So if you have sort of a small size adult, it's usually 50 grams. If you have a larger sized human, that's usually 100 grams. It comes in 50s and 100s. The normal max dose is at 100 grams. And it's mostly excreted within 3 hours if a patient has working kidneys. It is a little bit challenging to set goals, but most institutions will stop the administration once the osmolarity is documented above 320 microosms per kilogram or the osmolar gap is less than 20. I'm sorry, that should be greater than 20. Practically speaking, for hypertonic saline, it actually has a longer effect. And you can give any concentration 3, 7.5, or even 23.4%. Now, the trick here is that most institutions are going to require central access for at least 23.4%. Some institutions will allow 3% to be given peripherally. You really have to know sort of what is okay within your institution. But here, I think most of the time, this is going to preferably go through central access if you're using 23.4%. Most institutions will stop administration of hypertonic saline once the serum sodium is greater than 155 to 160. There's really no evidence to push it higher than that. All right, so let's talk a little bit more in depth here about how these are working. So mannitol may improve brain circulation because it possibly improves blood rheology. It has a reflection coefficient of about 0.9, whereas hypertonic saline has a positive inotropic effect, which can increase cardiac output, which might help your MAP and your cerebral perfusion pressure. It also has a faster onset of action. Now, let's really focus on the cons. So this really helps me determine which one I'm going to use, is which is the side effect that I'm least interested in having. So mannitol causes an osmotic diuresis. That actually can be quite profound. You can have a lot of urine output after mannitol because it's such a strong diuretic. You can imagine that for trauma patients who might already be hypovolemic or in hemorrhagic shock, that would not be a good thing. And so in our trauma population, we actually preferentially will use hypertonic saline. Now, hypertonic saline also has some cons. It's a small volume, but it's a lot of salt. So you can imagine someone who is already in decompensated heart failure. They're not going to do well with that, equivalent of a salty meal, right? And so I do not say that people who have borderline EFs, that they can't get hypertonic saline. But I do try to be mindful about using it if someone is truly in decompensated heart failure with pulmonary edema. This is not going to make them better. Hypertonic saline can also long-term result in a metabolic acidosis, which may cause some hyperchloremic kidney issues. So I think really for me, I'm trying to balance, what access do I have? If I only have peripheral access, I'm only going to use 3% hypertonic saline or mannitol. And then what is my comorbidities? Is the patient going to have, some sort of bad outcome if they are made hypovolemic? Or are they in heart failure and maybe that diuretic effect would be good for them? So that would shift me towards mannitol. Again, it's really thinking about the pros and cons that help me deliver and also knowing my institutional protocols. Now, what if you work at a small place and you don't have hypertonic saline and mannitol is available, but it's going to come from the pharmacy and it's not going to be available anytime soon? It is critical to know that hypertonic cold-carb bicarb also has a lot of salt. So if you are in a pinch, you can do about 2 amps of cold-carb bicarb, which is almost as much salt as the 250 milliliter dose of 3%. So if you're in a pinch or if you can't get your hands on these treatments, hypertonic bicarb to the rescue. All right, let's talk about ventilation goals. Many of our patients with increased ICP, because of that pressure on the brainstem, are going to have altered consciousness. Many will end up on a ventilator. Not necessarily everyone, but I think the majority of patients, if you're on the fence about whether or not you need to intubate them, I think it is reasonable to say, I will kind of act to intubate them first, make sure that I can control their ventilation, make sure they're appropriately ventilating, rather than be on the fence and someone who is, rapidly has a dwindling consciousness and you're not exactly sure what their trajectory is. So when you do have someone on a ventilator, what should your goals be? Well, obviously, you do not want them to be hypoxic. We want the arterial pressure of oxygen to be within that normal range. I aim for greater than 80. Your CO2 targets are really important because CO2 has a direct role on vasodilation and vasoconstriction. So CO2 is really potent in managing our pH. You can imagine for a pH that is low, so a patient who's acidotic, they are going to vasodilate. And a patient who has an increased ICP, Vasodilation would result in more blood flow going to the brain. Is that going to be good for our brain? No, it is not going to be too good for our brain because we don't want too much of a good thing, right? So we do not want to put more arterial blood component up if our box is already too full and herniation is about to occur. We actually really want to kind of focus on maybe a little bit of vasoconstriction. And the way we're going to do that is by gently hyperventilating patients, right? So when we hyperventilate patients, that's going to actually raise our pH, which is going to trigger vasoconstriction. We do not want to go overboard on this because, again, that arterial blood flow is delivering oxygen to our brain. But I try to target a CO2 of anywhere between 30 and 35 millimeters of mercury as kind of that safe. We're slightly hyperventilating, but we're not going to get into a danger zone of causing too much hypoxic injury to the brain. I specifically am trying to do this, especially if the patient's going to the OR and they're in a crisis and we're going to go and we're going to fix the problem. This is a great strategy to kind of short-term limit the ICP. Moving right along. So if even with hyperosmolar therapy, hyperventilation, and CSF diversion, and don't worry, we're going to get into CSF diversion in just a minute, you're still worried about ICP, then our next role is sort of deep sedation and intensive hyperosmolar therapy. So again, that is now we're moving from just like making sure the patient is not biting on the ET tube, that they're not, bucking the vent. Now we are using ICP, or we're using sedation as a way to control ICP. There are 4 agents that are best studied with this, which are propofol, midazolam, dexmedetomidine, and ketamine. So we're going to talk about the evidence for each of those. But in general, for short term, I tend to prefer propofol. Propofol has a really potent effect on decreasing cerebral metabolism, so it is ideal for ICP control. It's fast on, it's fast off. You can still get a neuro exam if you turn off the propofol. However, it can cause hypotension. And so it's really important that if you're going to start to use propofol, you have a pressor ready and you have the tools to deliver that pressor. So if you need a central line to deliver pressors, make sure you have that in place. Again, if we drop our map, our cerebral perfusion is also going to go down, and that's really causing secondary brain injury. Midazolam is also good. However, I think it can cause a lot of delirium long term, and it has a longer and less predictable half-life. Now, for patients who do not need deep sedation and their ICP is only mildly elevated, dexmedetomidine is a really great medication to keep them calm. It's good if you need intermittent neuro exams, but it does not have quite the same level of diminishing the cerebral metabolic demand, which then decreases the ICP. So not a reliable ICP effect. And finally, ketamine. So it used to be that in neurocritical care, we were like, nah, not a fan of ketamine. However, there has been a disproving of the long-held theory that ketamine causes increased ICP. And in fact, there's no modern evidence to support that. So it is actually, more neutral to the blood pressure. And so in some cases, when patients are really sensitive to propofol, we may turn to this. All right. Now, it's really important that if you're using deep sedation because the patient is in an ICP crisis, it is not a good thing to just turn off the sedation to kind of wake them up. Again, we want to be very mindful that if we're using deep sedation as a treatment, that we keep that sedation on, and we're doing neuro exam with sort of, just checking their pupillary reflexes and, making sure they have intact cranial nerves, but maybe not waking them up and agitating them. All right. If that sort of more intensive treatment of hyperosmolar therapy, targeting that higher sodium of 155 to 160, or targeting your osmolar gap of 20, and deeply sedating the patients. If that's not working, then we kind of have to turn to our tier 3 interventions, which there's less robust evidence for, and these come with some real downsides. So I really try to stay within the tier 0, that sedation, just, kind of like making sure everyone's hanging out and comfortable, hyperosmolar therapy and gentle hyperventilation, deeply sedating patients if they really need it. And I try not to have to get into these, but sometimes you just do, and the patient's ICPs are elevated regardless. Or if you don't have an ICP monitor yet, then you can see that they still have a unilateral pupil. They're still in a coma. Those would all be signs that you need to continue to escalate your treatment. All right. So tier 3, hypothermia and neuromuscular blockade. All right. So neuromuscular blockade can be really helpful for refractory ICP spikes. So it is preventing cough. It's also paralyzing your abdominal wall muscles, which is going to promote venous return. I find that this is most helpful to kind of briefly use for patients who are going to the scanner, right? So you're going to have to lay them flat. You're moving them around. That's an uncomfortable and that's a very sensitive time for neurocritical care patients. If I'm going to turn to if I'm going to turn to this, I tend to use it short duration, and if they need a scan. You can use cistercium or vecuronium. And really, I always try to actually use a rocuronium just practice dose or a bolus dose to see whether or not it has an effect on their ICPs before I commit them to a Nimbex strip. All right. When you're doing this, you definitely want to do train-of-form monitoring. You're going to ensure they are deeply sedated, right? We would never want to paralyze someone who's awake. In this case, we are always using EEG monitoring to make sure the patient is deeply sedated and does not have any consciousness that would allow them to feel that they're paralyzed. Shortest duration possible. Cannot emphasize this enough. It's like long duration causes, neuromuscular breakdown. It is not good for neurorecovery. It's going to really set the patients back. Hypothermia also is one of those things that we don't have great evidence to support. I am using it intermittently, but mostly I'm just aggressively trying to prevent fever. And we're going to get to that later on when we think about the principles of neurocritical care resuscitation. All right. So let's get there. So in this, we're just basically going to go over kind of what else is going on. So we've talked about cerebral physiology. We've talked about our tiered management of ICP. But the brain does not exist in isolation. In fact, what's going on with the rest of the body is really important for brain-centric care. And so our goal of neuroprotective care is to prevent secondary brain injury by optimizing oxygenation, increasing or optimizing perfusion, and making sure the brain's metabolism is supported. We're limiting the ICP spikes, we're preventing secondary ischemia, and this begins in the ED and continues through recovery in the neuro-ICU. So again, this is thinking more about systemic. What's going on with the body really affects what's going on at the brain. So spoiler alert, the brain really, really likes to exist in a normal environment. And so when we're doing glycemic control, temperature control, seizure treatment and prevention, blood pressure management, we are trying to keep things normal for the brain. So let's talk with blood pressure. We have emphasized over and over again how important cerebral perfusion pressure is. So because cerebral perfusion pressure equals the MAP minus ICP, we know the MAP is really an important component of this. We want to avoid hypotension, which would limit and decrease our cerebral perfusion pressure. This is incredibly important, especially in TBI. We want to aim for even a blood pressure slightly higher, specifically by the Brain Trauma Foundation. Remember, hypotension dramatically worsens outcome. Now, in some neuropathology, specifically in ischemic strokes, we really, really want to limit hypotension because we are trying to aim for permissive hypertension, right? So in a patient who has an acute ischemic stroke, we want to let their blood pressure autoregulate because that's getting collateral blood flow to the places that are ischemic. Really important, that will be covered in another lecture. In ICH and subarachnoid hemorrhage, we are trying to gently prevent hypertension while also preventing hypotension. So we need to take this seriously. Even though your brain sick patients may not look like your septic patients where their vitals are all out of whack, we need to be aggressive about monitoring. So that needs an arterial line, you need central venous monitoring, and you are going to aggressively titrate euvolemia. I think this often kind of gets swept under the rug, but these patients are just as sick as our systemically sick patients, and we need to treat them aggressively. Volume management is critically important, just like it is in all other critically ill patients. We are aiming for euvolemia. Remember that mannitol can result in significant diuresis, and so you need to be ready to give some fluid back if you're giving repeated doses of mannitol. Remember that sometimes if an injury progresses to severe brain injury, you can have accompanying diabetes insipidus. That would be something that you would notice because they have a robust urine output that almost looks like water. That is critically important to recognize so that you can use a multi-tiered intervention to make sure that those patients get resuscitated, and also we get to the bottom of why they're having that. Glycemic control is also really important to our patients. Spoiler alert, the brain really likes that to be normal too, right? So we don't want hypoglycemia and we don't want hyperglycemia. And so again, this is just being aggressive about treating people's blood sugar, making sure they're not hypoglycemic as a reason for contributing worsening to their neurologic exam. And so we are going to check finger sticks early. And then we are going to avoid glucose shifts, right? So we are going to use isotonic crystalloids. We're not going to give like D5W to anyone. We're going to, again, try to keep the brain in a normal environment. That's really what it wants to heal in. I also just say that, if you have the protocol to do so, making sure that these super hyperglycemic patients are on an insulin drip and they're getting that close monitoring that they need so we don't let them stay hyperglycemic for hours. That is not good for brain recovery. Temperature. So temperature in the world of neurocritical care has become sort of this ongoing, we just really want to figure this out better. So I will tell you that there is a lot of evidence in the animal models that show that hypothermia improves neurologic outcomes, particularly after cardiac arrest, which is basically the biggest stroke of a patient's life is when they undergo, having their heart stop. And so we have for years in neurocritical care said, well, if in cardiac arrest, the animal data shows that, hypothermia can help heal, is that the case in humans? And can we apply that to all brain pathologies? Is hypothermia better? And honestly, we really have not been able to demonstrate that hypothermia is better for brain recovery. However, we do know that fever prevention is certainly closely associated with patients who have worse neurologic outcomes. It is not clear whether hyperthermia drives those worsening neurologic outcomes, but it is closely related. And for now, we are in neurocritical care really focused on maintaining, you guessed it, normothermia. Again, the brain wants a normal environment to heal, right? So we want to keep the patients between 36 and 37 degrees Celsius. And we know that fever might be a bad thing for patients, even though aggressive treatment with devices has not been shown to improve neurologic outcomes. So again, this is just, we're seeing the same thing again and again, but just being mindful and monitoring this for our brain sick patients is just as important in people who are systemically ill. So that's putting in a continuous temperature monitor. It's being aggressive with acetaminophen early on. And then thinking about cooling blankets or other devices if the patient has really refractory symptoms. Now, seizures are going to be covered in a whole nother lecture, but I do want to just sort of introduce the concept because it's part of the fundamentals of neurocritical care. Seizure prophylaxis would be important. It's a good thing to prevent early seizures and high-risk neurologic injury, right? It reduces, when patients are seizing, that is a metabolically extremely active state for them. That's going to increase their metabolic demand. That's going to increase cerebral blood flow. That's going to potentially worsen their ICP. That is not a good thing. However, long-term seizure medications have a lot of downsides, and we do not want patients to stay on these indefinitely just because we kind of started them hoping to prevent a seizure. So let's take an evidence-based approach. In TBI, really important that they do get 7 days of a moderate dose anti-seizure medication. An aneurysmal subarachnoid hemorrhage, okay to use an anti-seizure until the aneurysm is secured, maybe a little bit longer in very high-risk populations. In everything else, we are not routinely using anti-seizure medications. So ICH, nope. Ischemic stroke, nope. Postoperative neurosurgical patients, talk to your surgeons, but in general, short duration, and it's not routinely recommended. All right. Remember to document why and how long the patient is going to be on it, because the biggest downside here is that they stay on it long term. All right. Now, we are going to have a talk about devices, and we're going to spend a lot of time in that device talk talking about ICP monitors. However, they inform how we monitor the fundamentals of neurocritical care. So I want to at least introduce the concepts here and then invite you to check out more lectures on this. So there are a lot of ICP monitors and the core ICP or ICU monitors that help us to understand the ICP. So there's both invasive ICP monitors, ICP approximators, and then there are monitors like continuous EEG. There are hemodynamic monitors, and there's temperature management. ICP monitoring for invasive can come in two flavors, which is your parenchymal probe or your external ventricular drain. And again, there is another lecture specifically on neurologic devices where we go into, why would you choose one versus the other? And I will direct you there. But in general, external ventricular drains are probably preferred in most institutions. The reason for that is, as you can see on the right side of the screen, these are placed to allow CSF diversion. Remember back to our little great graphic about what goes in our Monroe-Kelly box. CSF takes up a major component of what is in our skull. And so when a mass lesion is taking up more space in the box, we can shunt some of the CSF out of the brain to make more room. That cannot happen with parenchymal probes. You need an external ventricular drain to do that. So in most cases, these are really the gold standard because they not only allow us to monitor the pressure, but allow us to divert CSF. And diverting CSF is really part of our, tier 1 management. For patients who have obstructive hydrocephalus, for patients who have, the need for intraventricular hemorrhage clearance, this really plays an important role in helping to keep their ICP low. So again, just to go briefly through some of the limitations, our treatment threshold for this is whenever someone has a sustained ICP of greater than 20 to 22, that's going to trigger us to intervene promptly. One of the things that's really nice about having an ICP monitor that's invasive is that number is, more trustworthy than ICP approximations. And you can escalate up the tier if you have a number to guide the management. If you don't have an ICP monitor, you're going by the clinical exam, the radiographic exam, and sort of, your prediction of when the patient's pathology is likely to get worse. ICP monitoring allows you to have a number to say, the ICP is high, we need to escalate therapy. Or this ICP is low, our therapy is working really well. Maybe at some point we can start to pull off therapies. You always must correlate, though, with the clinical exam. So I have certainly seen patients who look fine and their ICP is showing much higher than what I would think it would be. So just remember that with any sort of monitors, there's limitations. You do not have to anchor on it as true if you have other supporting facts that show you a different picture. They can cause infections. They can cause hemorrhage. They are a global measure and may miss some localized pressure, particularly in the posterior circulation. And malfunction is definitely possible. So trust your patient over the device, but use the device to inform how you're escalating your therapy if you have one. Now, if you do not have an invasive monitor, fear not. There are non-invasive ways for us to approximate what's going on in the ICP. My favorite of which is pupillometry. So pupillometry is a way that we measure how quickly responsive the pupil is. And remember that pupil is sitting, the circuits that control the pupil are sitting in the midbrain, and they are really at risk for compression. So if your pupil is kind of sluggish and becoming dilated, that's a really important marker of increased ICP, and this is an objective way to sort of measure that. All right. Continuous EEG. There will be a whole nother talk about seizures and continuous EEG monitoring. In general, this helps us in the fundamentals is helping us to make sure that patients are not having non-convulsive seizures that would increase their metabolic demand and increase the cerebral blood flow and worsen outcomes. So for patients who we don't have a good neurologic exam, these can serve a really important part of our multimodal monitoring. Usually, we're monitoring for at least 24, 48 hours. This is a high resource, and so we work with our EEG encephalographers to make sure we're discontinuing it when we have the information that's no longer acting on. So it will detect seizures early, guide treatment, and prevent secondary injury, and there's definitely going to be more about this later in the course. EEG, practical points and limitations, it is resource intensive, and not everyone has continuous EEG. And so we just have to be mindful of this and use it if it's available and try to discontinue it as soon as we've gotten all the information we need. I have talked ad nauseum about how important it is to treat our neuro-sick patients just like a systemically sick patient. I'm not going to belabor it here, but it's really important to have hemodynamic monitoring so that you are being really deliberate about the blood pressure and you're using the neuropathology to guide those blood pressure targets. Temperature management, again, we've been there, but just to say again, we really want to prevent fever and maintain normothermia. We're going to do that by aggressively measuring and then doing acetaminophen cooling devices if needed, and medical treatment alone is not being enough. So we have covered so much in this fundamentals, but I really hope that this will serve as sort of the floor so that you can build your knowledge on all of these various topics, which are going to be covered in various aspects of the course. So essentials in neuro ICU, the monitoring is important because it helps you to inform the ICP care that you're giving to patients. And so when we're doing all of these different types of monitoring, the overall principle is that comprehensive monitoring integrates brain physiology with whole body care. It is not just about what's going on in the brain. It's about making sure that you are making a healing environment for the brain by optimizing every part of the patient's care. So treat impending herniation very aggressively using osmolar therapy, hyperventilation, and your positioning. You really want to maintain a CPP greater than 60, but certainly greater than that danger zone of 50. And you're going to do that by preventing hypotension and ensuring that the ICP stays low. Really critical to give the brain a resting environment by having the patient have, normal glucose targets, no fever, and, sedation and anesthesia have to be balanced. We want adequate pain control without massing the exam unless it's necessary to make sure that the ICP stays low. So much is happening in the field of neurocritical care right now. We're coming up with more and more advanced neuromonitoring. We're trying to figure out what's the exact right sedation dose, because certainly we do not want people to be, long-term on propofol, long-term on midazolam. That's not good for their overall recovery. And we still are trying to figure out exactly what the role is for hypothermia. For now, fever control or fever prevention really is key. So this is a really multidisciplinary approach. Every provider who touches this patient is having a real impact on their care, and that's neurosurgery, neurocritical care, PT, OT, emergency medicine, respiratory therapists. We must take a collaborative approach because these are really sick patients. So, overarching principles when we think about our fundamentals of neurocritical care: early recognition, rapid intervention. Your bedside neuro exam really should guide treatment. And if there's one thing you take away, it's the patient who presents in a coma with asymmetric pupils has an ICP crisis until proven otherwise. You have to have prompt initiation of neuroprotective measures to prevent that secondary brain injury. We cannot put the genie back in the bottle, but we can prevent the injury from getting worse. We need frequent assessments, and if it's feasible, and you have the resources to do so, having sort of advanced neuro multimodal monitoring really can give you a window into the brain. Dynamic adjustments. I always am emphasizing that it's not just about what's going on in the brain, but what's going on in the whole body that provides sort of the healing environment that the brain needs. And so continue to evaluate what meds are unnecessary. Is the glucose at the right target? Is the blood pressure at the right target? And is the patient sort of, optimally allowed to sort of be in their systemic normal so that they can heal? And with that, we will conclude this portion, and I am just so delighted to have been able to talk to you about the foundation and the fundamentals of neurocritical care.